All right, so welcome. We're talking about health literacy and AI today, but first I just want to get to know a little bit about who's in the room. So while we're giving folks 90 or so seconds to arrive, if you could just put in the chat where you're joining from, the type of work you do, and most importantly, one thing you're looking forward to this summer. Love to hear. Hi, Madonika, nice to see you. I know I personally this summer am very much looking forward to Pride in New York City this weekend. We've got the big parade on a Sunday, and I'm decorating my apartment rainbow for a brunch. It's going to be great. Ah, golf. Love it. Meditation retreat sounds amazing. California trip. And Michelle, that's a big trip from London. I love that for you. Chillin', Savine, that is the dream, honestly. More is not always more. I love this. Soccer game. That's so nice. That's going to be super cute. 46 high peaks is crazy. That definitely deserves a celebration. Nice. Pride UK edition. Incredible. So we've got a lot to look forward to. I love this. So I know the purpose of summer sessions is to keep this short and sweet because we all have a lot of fun things going on in this season. So thank you all for tuning in. We're going to keep today pretty focused, but I want to start with a story about why health literacy is so important and the many, many ways that it can go wrong when we're not being careful. So this is a classic story that's told in health literacy trainings about a man who was newly diagnosed with diabetes. He had to start insulin injections. And so he did the standard training that they do where they teach him how to do the insulin injections on an orange. So you're not practicing on your own human skin first because that hurts, but you're practicing on something that is pretty approximately similar. He did the training successfully. They congratulated him on being a good insulin injector and sent him home to live his life. Not long after, this man ended up in the hospital, and they were trying like crazy to figure out why his diabetes was just out of control to the point of hospitalization. They asked him, have you been taking your insulin? He said, of course I have. I've been injecting it every day. And, the problem was still there. So they kept digging, and they eventually found that by injecting it every day, he meant injecting the orange every day and eating it. So this man had taken the instructions a little bit too literally. There was a gap in information left based on some assumptions and understanding, and it led to a pretty serious health issue. This is something that might seem a little bit extreme, but it's a really good example of how things can go wrong, especially when we're writing from a perspective of folks in the healthcare industry. We do have a lot more background than most people, and we're not in the same headspace as someone who is going through something new and stressful and quite physical. So important to keep in mind. Quick intro. My name is Suzanne, for those who haven't met. I'm the founder and CEO of Verelon, a behavioral science consultancy focused on the boardroom, not the lab, meaning very applicable to real-world healthcare, AI, and change management. Outside of that, I am a lecturer, a writer, and a startup advisor. I've previously been the CEO of North America of a global behavioral science consulting company called BVA Nudge Consulting, and was co-founder of the social science division at McCann Health, which is a leading health care marketing agency. So I want to make sure you feel like you're in good hands, especially when it comes to health literacy. This is one of my favorite topics. I've been working on this since the beginning of my career, publishing various publications, including a Cochrane systematic review on health interventions for health literacy, and training many, many pharma, medical device, biotech companies that I can't name necessarily, but also the New York City Department of Health and Columbia University's Mailman School of Public Health. So this is something near and dear to my heart, and I'm excited to share it with you today. But before I share my thoughts, I want to reflect back to you what I heard in your registration answers about your challenges with health literacy in this day and age. Big one was around data. We are overwhelmed, and if we are overwhelmed, the people we are writing for are almost certainly overwhelmed. Another big question related to that: what should stay? What can be simplified? What may need to be removed? These are things that become very difficult when there is an abundance of information. And then really practically, teams are not clear on what action they actually want patients or even HCPs to take. The big theme I was seeing in all of your responses was judgment. It wasn't, how do I write at a 5th grade reading level? It was, how do I decide what and how to present the information that I need to present? So we'll come back to judgment and how we use that later, but just to reflect back to you, perhaps make you feel a little bit less alone. So we'll get to the AI in the second half, but I first want to make sure we all have the same grounding in the essentials of health literacy itself. So Healthy People 2030 initiative actually updated the definitions of health literacy a few years ago. So the first half of the definition is the half that we probably already think about, which is personal health literacy. It's an individual's ability to understand and act on information related to their health. Fine, straightforward. The second part that they added to this definition is organizational health literacy, which is the degree to which organizations equitably enable individuals to find, understand, and act on health information. So they've taken the onus off of just the individual and their skills and put it on the folks who are producing the information that is out there, which is us. So this is very much important from both ends, but just so you know, that is how the world is thinking about this now. This is everyone's problem. And that's true in more than one way. A lot of studies have shown that in the US, most adults have very low health literacy. Only about 12%, or just over 1 in 10, have proficient health literacy, which is defined by being able to understand this statement: take 2 pills twice daily. Because that could be a little bit ambiguous, right? Is that I take 2 pills total at 2 different times a day? Do I take 2 pills 2 times a day? There's interpretation that needs to happen in this very, very common sentence. And only 12% of people are equipped to do that correctly in the US. So this is something that spans all different backgrounds. This is not a certain demographic or type of patient or type of doctor. This is everyone. This is hard. So this is something that we should assume as a baseline we should always be taking into account. This is intuitively important, but just to make it concrete, folks with low health literacy have worse health outcomes, including more hospital stays and emergency room visits. They make more medication errors, have trouble managing chronic diseases, and skip more preventative services, which is, of course, worse for their health, but it also costs the US economy a massive amount of money each year. There are lots of different estimates out there, but they range from $200 to $600 billion per year. So there are many, many good reasons for us to get this right. Before we go any further, I want to make sure I'm really clear. Health literacy is not just for patients. Health literacy is for people. And you've heard this as the conference punchline before, but healthcare providers are people too. People who are busy, stressed, and tired, as we all know. And people who are busy, stressed, and tired have a much lower ability to process information. That's one reason why this is important for healthcare providers too. Everybody appreciates simple, clear information. The other part is if we are giving patients layperson-friendly language, but we're still speaking to healthcare providers with very high science language, and then we expect them to get in a room and have a conversation, which is something that we definitely want to enable, we're then putting the responsibility of translating that science on the doctor or the nurse practitioner or whichever HCP we're speaking with. That is not a skill most have. That is something that's hard to do, as we know from our own work, and it's something that takes time and effort, and they're probably not going to do it right. So we're actually setting ourselves up for failure by giving them different language. So if we give the whole ecosystem language that's coherent, when they come together, they will successfully meet in a conversation where they can both understand each other. So this is something that's relevant to everyone. Just to make this point a little bit further, there was a great randomized control study that was done with physicians where they were presented with a hypothetical situation of a patient with lung cancer. They had the choice of radiation or surgery for this patient. And in this randomized control study, they presented half of the doctors with the mortality rate, which is 10% chance of death with surgery. The other half of the doctors were presented with the survival rate of surgery, 90%. Mathematically, these are obviously the same thing. And if doctors are really as data-driven and rational and evidence-based as we like to think and as they would tell us they are, this should not change their decision-making. It shouldn't matter. We're saying the same thing in terms of technicalities, right? But this study showed that when you present the mortality rate, doctors were 2.5 times more likely to choose radiation because we've drawn attention to the negative aspect of that decision of surgery. And so it put them off, right? They were more likely to go the other way. This is a crazy difference in a very serious decision, right? This is a cancer treatment. So if just this simple flip of the coin in terms of how we present data leads to such a different decision, it's so clear that this is really important. And again, doctors are not immune to the patterns of the human brain. So today is obviously short and sweet, and we want to get to the AI part, but I want to make sure we do cover some of the core techniques of doing good health literate communication. So of course, there's the content, which is what we're communicating. Most people, if they know about health literacy, they assume it's about reading grade level, which is absolutely part of it. It's part of the content. We want to be aiming for usually 5th grade reading level if we can. It's harder than you think to do, but it's really important. But that's only one piece of just this one bucket of health literacy communication techniques. Other things in this bucket include the order in which you present things. The most important thing should go first. Should include not having too much information. We don't want to have overwhelming amounts of things that we need people to take in. And it should include a call to action. This is important. We want things to have a purpose, a behavioral purpose, not just an information purpose. That's the content overview. Then the design, which is how we present information. We want to think about things like chunking. We never want to see big paragraphs of text. We want to literally put it in chunks with white space, ideally with bullet points or call-out boxes, informative headers, bolding the important words, anything that makes it visually easy for me to see what is important. Especially if we're talking about digital communications, people are not reading when they're looking at a screen, they're skimming. And so you want to visually design your materials so that they are skimmable and still convey the most important points without people reading every word. Then there's the channel, which is in this case both where and who is conveying the message. This is very specific to audience and message and the combination thereof. So this is something that you'll have to figure out in your own situation. But where could be, yes, is it going on a Facebook ad? Is it going in a poster? Is it going in an email? Is it going on a brochure? All of those kind of formal communication channels, but also informal. Is this being something conveyed at a meeting? Is this something we're talking about in a community advocacy organization session? These sorts of things. The who is the messenger. And if anybody has ever met a teenager, you know that saying the same thing but coming from a different source, friend versus parent, can be received completely differently. And it's the same thing for any other kind of message, especially in health. So think about, is it better for this to come from a big pharma company name? Is it better for this to come from a named person? Is this better to come from a peer? Is this better to come from a patient? Think about who is the best delivery mechanism for the what. And then inclusion is really important. In public health, we talk about this as nothing about me without me. So we should make sure that the target audience has a say in as much of the process as we can so that we make sure it's going to resonate and be effective. Last note in this section is important. I've been asked a few times in the lead up to today about misinformation and disinformation and how that plays with health literacy. And it is absolutely relevant. We know that false information spreads faster and wider than the truth, unfortunately, whether that's intentional or not. And so the health literacy becomes important because clear and trustworthy communication helps to make sure there are not gaps in people's understanding that can be filled by things that are incorrect, but perhaps a little bit appealing. So health literacy plays a role in fighting against mis and disinformation. However, there's a lot of really interesting and a little bit complicated behavioral science behind why and how that works, and then all of the different things that we can do to combat it really effectively. So that can be a whole session of its own. If that's interesting to you, please let me know. I'd be happy to maybe make that one of the later summer sessions or just have a conversation about it because it's very important. So that's our health literacy grounding. Now we're going to talk about the shiny new stuff, which is AI and health literacy. So as we know, AI is good at things like speed, volume, sounding really fluent and polished, and that's great, right? That is something that is good for us. It's also creating a bit of a mess because we already talked about we have too much data, we have too much to prioritize. So strengths, pros and cons. It's not black and white. However, when we talk about AI weaknesses, they become pretty significant, right? We want to talk about what is the real goal of any communication? What are we actually trying to do? AI is not going to know that. Deeply understanding your audience and not just demographics, but the emotions, the decision-making patterns, the context in which they are, and when they receive this information, it doesn't know how to take that into account. That's much more nuanced and complex. And then, of course, navigating real-world constraints. We are not just creating materials in a vacuum. We work at companies with budgets, timelines, colleagues, med-legal review processes. And so these are all things that need to be taken into account when we're actually creating and getting effective health communication out into the world. So before I tell you more about what you guys said you're using AI for right now in your registration questions, I'm curious to take the temperature of just assumptions. So if you can type in the chat, what percentage of pharma and agency teams do you think are using AI in their patient or HCP communications today? 95%, 80, 70, 85? 90? Ooh, 50. Great. 40? 10. So we really don't have a consistent intuition, right? It's tricky. It's kind of a weird invisible behavior. Most of us kind of assume like everybody's using this all the time, right? And some of us are saying, no way, but the range is telling, but also the mode is telling. So I haven't done, formal research, but from what you said, most of you are not using it at all, or you're using it for internal communication but not for external communication. For the folks who are using it, most common answer was for plain language summaries and reading level checks. So that's great. We talked about that as being an important part of the content bucket, but as we saw, there's a lot more to health literate communication than just that, but it's a great starting point and it's a good use for AI. I also heard from you various things like first drafts or brainstorming or helping to guide the teams who write. I wanted to share this because I think it's really important because it can be very easy to feel super overwhelmed by AI and feel really behind. And that sort of turns into a death spiral of just getting further and further disengaged or afraid of AI and then not leaning in, not using it in the best ways. And so I want to demystify that and show that you're probably not as behind as you maybe feel, or maybe it looks like when you read people's posts on LinkedIn, and make it seem more approachable because this is something that is happening. It is a useful tool when used correctly, and I want to make sure that this feels like something that we can all do, which it is. So we've level set there. To bring it all together into one big framework for you, taking into account, yes, you can just tell AI to do a read and grade level thing or a plain language summary. That's nice. We've already established that's not what health literate communication is. Health literate communication, as you said in many of your challenge responses that we talked about at the beginning, involves judgment and decision making. So I've created this framework for you called the APACE framework that lays out the 5 key decisions that help you create the most effective health communications that are going to make sure that we actually change behavior and make an impact. So APACE starts with A for action. This is the most important. When I work with teams who are creating health communications, one of the first questions I ask is, what is the behavioral goal of this communication? And that is usually where people realize that behavioral science is a different lens, because they thought that education was a goal or awareness was a goal. And as far as anybody is concerned with a behavioral science lens or a business lens, that is not a goal, because our KPIs are not awareness or education. They are prescribing or adherence or things that people do that we can see in real life. So every material should have some action as its goal. Could be a big thing like prescribe, could be a small thing like go to the website, but there should be something that you want someone to do as a result of that communication. When you can get really clear and really specific on this, that makes most of the rest of your decision making significantly easier. So that lens is already usually different for most people. Action is up top because it's most important, and the rest flows from it. The rest of APACE is P for priority. So once you know what your action is, you need to decide to get to this action, what is the one most important thing I need to convey in this piece? That is how I prioritize, right? We talked about we have too much data. How do I know what to leave in, what to change, what to simplify, what to leave out? How do I know what action people need? Once you've determined all of that, priority kind of answers itself, but it's something that will help you keep your materials clear. Often we fall into trying to pack a bunch of different stuff into one piece of communication, thinking, gosh, we got to make the most of this moment. We got to educate people. We got to get it all across. But that just leads to people being overwhelmed and not taking in any of it. And you're better off not having done it at all. So less is more. The second A of a PACE is audience. This is something that we're used to thinking about. Is it a patient? Is it an HCP? What treatment area? What specialty, etc.? Maybe their demographics. I want us to think further about the human of the audience, right? Is this person stressed? Have they been newly diagnosed and they're freaking out? Are they 5 years in? They're just kind of tired of this conversation, but they're pretty experienced. Are they a really busy doctor? Are they a new doctor? Is it their practice? Or are they in a big hospital? This is where we bring in more of that behavioral science lens, decision-making patterns, emotions, cognitive biases. This was where you start to really personalize, and this helps you to drive towards that action in an effective way. The C is for constraints. When we talk about constraints, of course, we're talking about med legal requirements, which we want to respect, but we're also talking about the practicalities of working in the businesses that we work in. We have timelines, we have budgets, we have teams that we need to collaborate with effectively and play nice with. We have other projects on our plate. We need to think about the real world when we're creating these and factor that into how we're developing these, the process that we're going through. We're not creating these in the abstract, and so we need to plan accordingly. And then the E of a PACE is evidence. And by evidence, I'm talking about looping back to the beginning of the action. What evidence would show that we have achieved the action goal of this piece? There's a lot of talk right now in medical affairs and commercial side about impact and measuring impact. We know this is tricky, but this is something where if you've been really specific about an action that is the goal of that piece at the beginning, the evidence metric kind of flows from there. You've set yourself up for success on impact measurement by defining action really well. Sometimes we can't measure exactly what we would like to measure, the actual behavior. So then we need to figure out what are the leading indicators, what are things that are hints that it would be happening if we can't measure it directly. But these things determined explicitly ahead of time will help you create better communications using your human decision-making, aided by AI or not. But this construct will help you be more systematic. So I know that was one quick slide with a lot of new information on it. I've created a PDF reference sheet for you that we're going to drop into the chat now that you can refer to going forward. So that should show up any second. In the meantime, I just want to convey that this is not abstract, theoretical, academic information, right? A big priority of Verelon is making this practical in the real world. And so here's a case study where I've worked with a team to improve their communications ecosystem, train their contact center representatives in health literacy communication techniques, behavioral science techniques, and that led to a 3 times uptake in their treatment, and 92% of patients likely or very likely to ask the doctor about their treatment. So just to show you very briefly that this is not just theory, this works in practice and makes a significant difference. I know some of this can seem simple, but it's deceptively so, and most people miss it. So doing it systematically on purpose every time is how you get some really significant results. I know today was short and sweet. That was a purpose of Verelon Summer Session number 1. But if you have any questions about the PACE framework, how to put these 5 decisions into practice, anything about the health literacy core techniques, I'd be happy to chat with you about it. Please just get in touch. And then I have a last question for you. I'm curious to get your feedback or thoughts, either now or later. I'm in the very early days of creating a behavioral science and AI-based engine to help test materials against simulated clinicians and patients before launch, incorporating all of the things that we just talked about and more. But also that engine would let reps and MSLs rehearse with realistic HCP personas before going out into the real world. So very, very early days, still exploratory. I'd be really curious to know if this is something that sounds useful or interesting to you. Happy to chat later. Please reach out. All right, well, thanks everyone. We can let you go. Very express as promised. Thanks for attending the first Verelon Summer Session. I'm looking forward to seeing you at the next one next month.